Okay, hi, my name is Anna Bican. I am one of the ex officio members with the UDN PEER, and I'm here to sit down today with Dr. Rizwan Hamid from Vanderbilt Clinical Site and interview his experience working with the UDN. Welcome, Dr. Hamid.
Thank you very much, Anna.
So we really do appreciate all your support for the UDNF and the UDN PEER as we've been working so hard on sustainability for the UDN. You're one of our champions.
Thank you.
Um, So I think that we are very excited to get this opportunity to talk to you today. And I'll just kind of jump right in. We have a few questions about your background and experience in the undiagnosed and rare disease world. So um, thinking about your work at Vanderbilt, how long have you been with Vanderbilt?
So I have been at Vanderbilt for a long time. I came here in '86 as a student, and then essentially stuck here for long periods of time. As a faculty, I came here in 2003. And I'm currently the director of the Division of Medical Genetics, and one of the co-PIs along with John Phillips and Dr. Kogan of the UDN Clinical Site.
Awesome. So, and you have you done research before UDN related to rare disease or other areas?
Yeah, so I'm a physician scientist. So in addition to obviously having a passion for patients with rare unexplained disorders, my lab works on very rare lung diseases that are inherited in families. This disease is called pulmonary arterial hypertension, which is a lethal disorder. And we use all sorts of techniques to try to find why that happens in patient and whether there are treatments to be found that can eventually help these patients. So from that experience, and so we have used that experience that is from my lab to great benefit in helping our UDN patients because techniques to identify genetic causes of rare lung disorders is essentially the same as technique used to identify a rare cause of development delay or seizures, et cetera, et cetera.
Wow. Well, you definitely seem to have a passion for our patients in the rare disease world. Maybe more so than others. What do you think, drives passion for you?
So I think so I would just say that most geneticists, so I'm a clinical geneticist, I'm a clinical and biochemical geneticist. So I would say is that most the physicians who go into this specialty actually have a passion for rare disease. Otherwise, they wouldn't go into there. They would actually go and be a cardiologist or a surgeon. So I trained I did my training at Vanderbilt, clinical training, and pediatric training at University of Miami, but I was always interested in patients with rare disease because I thought that there was really very few people out there trying to help these patients, and very few physicians going into this field because this field, as anybody can, as many of our families are aware, doesn't generate any revenue for either the physicians or the institutions that they work with.
Hmm.
So there is a huge shortage, but I was interested in from an academic point of view, which is, you have these patients with medical mysteries. Can we use the new genomic approaches? And I'm talking about approaches that are available in year 1997, 98, 99. And obviously the landscape is different right now. But to get back to the question, I think it is most geneticists have a passion for rare genetic disorders and have training to actually diagnose this. The reason many times a patient is not diagnosed or the diagnosis is difficult to reach in a clinical genetics clinic is that you don't have the research-based resources to actually then follow your clues. But my passion would not be any different than geneticists working in Dallas or geneticists working in Orlando.
Yeah, I think the geneticists that I've met, they seem to mostly be able to cross over that pediatric and adult divide. And I love that, that these specialists who've trained and especially seem to know a little bit about all ages of patients. So you really have that eye for rare disease, no matter how old the patient is.
I mean, that's true. Most geneticists, even though we are originally trained as pediatric geneticists, most geneticists actually do get training to even see adult patients. And, in our clinics or even in the UDN program, nearly half of our patients are adults, and we are able to help them.
Wow. Well, so you've been working on this for quite a while. I think UDN started in 2013, 2014. So what would you describe as your definition of success at this point?
A very good question. So I think it depends who you ask this question. So a simple answer would be a definition of success is that we found the answer at the end. But I think that would not be a great answer, because I think what success is means something different to the families compared to what it means to the doctors, compared to what it may mean to another family. And I think to us, I think the definition, the way I've thought about it is, and I've come to a realization on that, is the definition of success for me is, were we able to do everything we could do to solve that patient's puzzle? Were we able to leverage all the latest scientific advances that are available in year 2022 to attempt to answer that patient's the question raised by that patient, or to end that diagnostic odyssey. I think that would be the most honest definition of success, because while it's easy to say that are we able to leverage all that latest technology, but in reality, that can be very difficult to do, because it requires a lot of collaboration from other scientists and physicians, and that many times is difficult to come by. So I think, my definition would be, was I able to get other scientists around Vanderbilt or other institution interested in a particular patient's story, and were we able to then use each other and help each other find the answer. And one of the things to remember is that in UDN patients, the answer may not come right after you see the patient, or even 1 month after you see the patient. But these collaborations that we develop sometimes actually bear fruit 4 years, 3 years, 2 years down the road. And unless you have these collaborations, I think you're not going to get there. So I think about in summary, I would say developing a collaborative team that can spend time looking at the patient using all the latest scientific advances would be a definition of success.
That makes sense to me, because my own husband has a rare disease, and you know him, so I know you know his story, and it's only because of the way that the doctors collaborated at Vanderbilt that they were able to eventually figure out that he had a rare disease and what it was. We're lucky that it was a treatable disease. His rheumatologist saw the report and it was a VUS. So him not being genetically trained, he said, well, I don't know. I guess this isn't it, and I had just talked to your wife, Joy Kogan, that day about that report and asked her, what does this mean? And she had given me hope that there was an answer in there. So when he came to my door, like deflated with, I don't think this is the answer, I was like, have you met Joy Kogan? and
Yeah, so I think this does bring up another question or other point, I would say, that I think what we feel like, which has been a strength of our Vanderbilt UDN site, is this collaborative spirit. And I think we have been immensely fortunate to have a group of scientists, physicians, collaborators, nurse practitioners, genetic counselors, other geneticists who have worked selflessly to attempt to solve these medical mysteries. They have never asked, hey, what is in it for me? And I think that has been, we have found this to be, I think, the driving force for our site's success in helping as many patients as we can. You know, having been in an academics center, I will tell you that that sort of collaboration where people and other departments and other programs, you know, giving you time uh, is much rarer than one might think, because everybody is busy. And so I think a lot of that has to do with how Vanderbilt structure is set up. Some has to do with the sort of Vanderbilt collaborative um, uh, uh, approach that my co-PIs have used, like Dr. John Phillips and Dr. Joy Kogan and Dr. John Newman, who's now retired, but used to be part of the UDN. So I think that has been a strength for our program, ability to call upon people, you know, our ability to just knock on anybody's door and say, hey, I have a problem, I have a patient, 70-year-old, 2-month-old, here's a problem they're having, and I think you can help us. And rather than those people shutting the door, I think those people have been super helpful, and really and more often than not, the response we have gotten from them is, hey, yeah, tell me how much I can help you and how can I help you.
You were telling me right before this about a patient that stands out to you that had a really collaborative story. Do you want to tell us about that patient?
Yeah, so I think so honestly, I would just say that pretty much every case that we have had, we have seen this collaborative spirit. After all, our Friday genome database meeting that happens have over 30 different scientists and
Wow.
collaborators that take part in that meeting. And we don't have to twist their arms to come to that meeting. And they don't really get anything else out of it, except for the fact that they know they're helping some family, some patients somewhere around the United States. But I think one of the cases that stands out to me, and not just stands out to me from our own point of view, but a case that I think demonstrates the wonderful collaborative spirit of this network, is this patient that we saw, a young gentleman who had a lot of medical problems, who had a somewhat big head, was very small, had development delay, had hearing loss, et cetera, et cetera, et cetera. And the very heartening thing about that case was that while we identified a potential answer for that family, we were then able to call upon a wider network of UDN scientists and doctors at other institutions, including NIH, including University of Washington, University of Oregon, who then actually, including non-UDN researchers like University of California, San Diego, who were then able to pick up on our clues and then help us really, what you call, nail the answer. This team involved folks from NIH UDN site. So we found the answer in this case. It was a 2-year journey, but we actually did find the answer in that specific case. And then the cool thing about that story was that we were able to then identify over, and I may be wrong exactly the number, but over 50 patients around the world in in countries as far away as Sweden to Brazil, who actually turned out to have the same disorder but were previously considered undiagnosed. So all of us in the UDN program and the Vanderbilt collaborative investigators working together, finding the answer, then help a wider network of over 70 patients. And by now, I'm sure the count is much higher, because we are talking about a story that happened nearly 4 years ago. So we were able to help essentially a wider number of patients who had the same disorder but had undiagnosed diagnostic odysseys. Suddenly they had the answer. And now with all the cool therapies that are coming down the road, potentially down the road, a way to even treat this condition. So I think that story stands out to me just because it showed the wonderful collaborative spirit that is in place in the UDN program, and which is, I think, the strength of this network. And I think it would be shame to see that sort of collaborative spirit go away.
I think
And
I have a picture here of him, right?
yeah,
Uh,
that's the gentleman. And I think that is what I think the peer group understands and our families understand, is that it is the sum of we have currently 11 UDN sites, and we can 1 plus 1 plus 1 plus 1 11 times. In the UDN case doesn't equal 11, it equals 1 million, because all these sites, actually there are 12 UDN sites. I forgot the NIH site, but I think it equals the synergy that develops, the back and forth that has developed from this network is just amazing. A resource for, I think, for us nationally in the United States, amazing resource for these patients who are seeking help.
That is so powerful. And I think this case was one that highlighted some of our other researchers, right? The scientists that do model organisms research. That's not typically available outside of UDN, right?
I know, exactly. That's what I was talking about. This work was done by Dr. Monty Westerfield in Oregon, and it took nearly 2 years to do. And we were able to look at the patient's genomic change and then make a zebrafish model, and that required collaboration on his group part. And then we were able to also look at cells, and that required collaboration on investigators from NIH's research labs. So just an amazing, wow. I think this is an amazing story that connected all these different dots. The work started in our case, and our group of 30 investigators found the particular mutation, and then our wonderful collaborators who then contributed to pinpointing why this happens and how this happens.
Well, and then you can see here, even on the publication, just how many names are authors. It's
incredible. Yeah, exactly. I think that's a great example of a collaborative spirit of the UDN, which I think we need to preserve.
Yeah, well, so do I. So how can we expand the reach of the UDN? How can we help more people?
I think keeping this network alive is important. Okay, I think funding this network appropriately is important. Rather than saying this network ends, you need to think about how do we keep the network going? How do we improve the resources that are available to this network? I think those are the sort of important things that need to be done. Obviously, one way to think about this also is that we can do, are these big medical institutions doing enough locally at their own level to help expand the reach of the UDN? So, for example, at Vanderbilt, we started thinking in terms that, NIH may not be able to fund this network beyond 2022. We started work in 2014, 15, 16 to try to convince our leadership that these patients are not a lost cause, and an institution like Vanderbilt should be committed to helping these patients outside the scope of NIH funding. And I'm happy to say that we were successful to convince our leaders, our dean, Dr. Jeff Balzer, and Dr. Jeff Balzer. We were able to convince him that an institution like Vanderbilt needs to commit their own resources to expand the reach of the UDN. So even if NIH decides to continue to fund this program, the funding from our institution will allow us to help more patients, because as many of you families know, the funding from NIH is only, many times, depending on which site you are is either for 30 patients or 15 patients a year. And that is nearly not enough to help patients. So you need other ways to, even if this network continues in this current state, and that is a big if, you still need other ways to help these patients. And I think institutional support is key. And I think I'm happy to report that I think Vanderbilt is one of the first institutions that have committed hard dollars into, have heard us, know the importance and how helping these patients is in this mission, in their mission, to help patient populations that are essentially underserved, and this population of patient is, right? I mean, these patients are really, in some ways, you should think about is, these patients are orphan patients. These patients who have undiagnosed diseases, if you have a rare type of, a rare type of genetic disorder, let's say you have muscular dystrophy, there's an organization that is fighting for you, okay? But if you're an undiagnosed patient, so you're in a diagnostic odyssey, where is your group? Who's fighting for you? You don't have any groups. So these patients, programs like ours, the UDN sites are their only hope, who can fight for that. And I am so happy that our institution, Vanderbilt, essentially said to itself and to us that, okay, we are going to continue to be a champion for these patients. And we are, regardless of whether NIH decides to fund you or not, Vanderbilt will continue to devote its own resources to continue to help these patients. And which is, if you think about it, which is an enormous challenge, because most big institutions would be reluctant to spend their own money on patients where there may not be a definitive answer. So I think that's how you expand the reach. So that's one way to expand the reach. The other way to expand the reach for the UDN would be to convince your state legislatures to maybe fund programs at the state level. Obviously, the problem with that is that program is only then helpful for your state patients. But we have made some progress working with our Rare Disease Advisory Council, of which I'm a member. We are working with our legislatures in the state to see if the state of Tennessee will allocate some funds down the road so that at least the patients who are undergoing diagnostic odyssey in the state of Tennessee can have some resources available from the state. These resources will be provided to the big medical centers in the state. So that would be another way that we are doing, other way that we are trying to raise awareness in the state level, as well as raise support from state legislature. But that, for me, I have found out that is an interesting journey. As physicians, we many times are not involved in regulatory matters, but we are cautiously optimistic that 1 or 2 years down the road, that we would have a program here, in addition to our institutional support, a program that, at least for patients in the state of Tennessee, works. Patients in the state of Tennessee who have undiagnosed or rare disorders will have some support from the state. And if that model works, then we will be happy to promote and give advice to pretty much anybody, any other state who would want to try that model. But having that model work in one state would automatically give data to other states, other peer groups, to say, okay, if Tennessee is making it work, why can't we just do it in Ohio? And listen, this is how they make it work. This is how much money they saved in overall medical cost, et cetera, et cetera. So I think those are some of the initiatives that we have done locally. Obviously, as you can imagine, we are all behind the peer group and clapping from the background to all the efforts that peer group is doing to get NIH to change their mind, which is fantastic.
Yeah.
but we have some contingency plans in place, at least at our site.
That's good. It seems like as a physician, you're increasingly being asked to wear additional hats now, legislature advisor as well.
Well, true, but I think peer group is doing a lot of the hard work. I think which we are as UDN doctors super supportive. I think we understand the importance of that work. I think the peer group understands the importance of the work. Sometimes it's just difficult to folks who are not in the rare disease community to make them understand how unique
Mhm.
is this wonderful network and
Yeah.
how committed these doctors are. And I'm not just talking about myself, I'm talking about all of the UDN doctors. All of us spend a lot more time than on this program. Essentially, we spend, even though I have a big research lab and I do other stuff, I find myself, I spend 75% of the time in the UDN program, even though technically I'm not supposed to spend that much time on the UDN
Because
program.
it's the most fun, I think.
Well, I think it's the most, one way to think about the UDN program, what drives us is UDN program is a perfect example where you can use the current science to help the patient today,
Yeah,
right now.
that's true.
So if I do research in pulmonary arterial hypertension, and maybe 20 years down the road, or 10 years down the road, or 50 years down the road, somebody else will build on my work and maybe find the solution for those patients, right? So that's how research works typically. That's how long research works that way. But the UDN program, as physicians, the reason it is so fulfilling is that all the cool research that happens, that NIH spends billions of dollars doing research on, we can actually, all those techniques and technology that is developed, we can actually use that to help each individual patient one by one.
Mm.
And which is, it can never happen in any other sort of program. And that's why we think that, I personally think that UDN is such a unique program. And there's not such a program anywhere else in the world.
Yeah.
And those sort of approaches are difficult, or utilizing them in patient care, it's just difficult to do. Insurance companies don't cover for the cost. And many other institutions obviously are not going to have institutional support. We are lucky, obviously, we have the institutional support. But so the support has to come from some other place, right?
Mm-hmm.
And I would say, based on our productivity, that for the tiny amount NIH spent on the UDN program compared to their overall budget since 2004, I think they've got pretty good return on their dollar.
I'd say so. Yes, for all those who have gotten answers, I think we'd all say so. And, even not getting answers, so many of the families in the peer group have at least gotten that sense of validation that they're not alone in this. There's doctors that believe them, that are caring about their case. And I do think that we just really, really are so benefited by you and all the other doctors that are researchers in this study. So thank you so much for your time today.
Hey, happy to talk. And if any member of the peer group has any other questions, they can directly reach out to me. As you can imagine, I can talk and talk and talk about this topic. Thank you so
Well,
much, Anna.
thank you.
Bye.
Bye.